morning, everybody. Thank you for this invitation to choose Malta. So we'll move on and start with the lectures. And we'll start with Dr. Ruggiero from Treviso, total laparoscopic colectomy with Alexis Wunderkrafter. Please, Dr. Ruggiero.
Good morning. This is our experience with the Alexis system for colon extraction during laparoscopic total colectomy. In the last 5 years, we performed 3 of them. The indications were Crohn's disease in one case and ulcerative colitis in 2 cases. As you can see in the photos, Alexis system was placed in the umbilicus, and 3 other operative trocars were placed in the right and left trunk and left hypochondrium. Colectomy was performed with a 12 mm stapler, and the colon was extraction through the Alexis. At the end of the procedure, the permanent ileostomy was formed in 2 cases, and in 1 case it was already formed. The length of postoperative hospital stay was 7 days, and no complications occurred. In conclusion, in our opinion, Alexis system is a good, safe, and effective option to avoid laparotomy incision and to obtain an excellent aesthetic result. Thank you.
Thank you, Dr. Ruggiero. Question from the audience? Thank you. Thank you very much.
So we move on to the next presentation, next poster, our experience with retrograde balloon dilation in the treatment of congenital uretero-pelvic junction obstruction from Dr. Tulio Moreno Alfonso.
Good morning, everyone. Our aim is to expose our experience through a case series of our management of congenital OPGO treated with retrograde balloon dilatation between 2015 and 2021. We perform all the cases with a cystoscopic approach. It's a retrograde angioplastic balloon with high pressure ventilation and with a range balloon from 3 to 6 millimeters. In all cases, a double J catheter was placed, and in all cases, it was performed a calibration during the double J window in order to consider a new dilatation. We had 25 patients. We performed 1.6 million dilatation in each patient with a mean operative time of 41 minutes. The hospital stay was just 1 day in all the patients. We only had 1 complication, which was a urinary tract infection in one of the patients. And we had an interval between dilatations of 1 month approximately. We had a maximum improvement in 60% of the patients in the series, and 32% of the patients had to underwent pyroplasty as a penile surgery. In our conclusion, this is a safe, minimally invasive first alternative for this pathology treatment option. Thank you very much.
One question, did you, in your cohort of patients, were also the patients with the lower pole vessel included?
Sorry?
Were the patients with the lower pole vessel included?
No, we consider these cases, it was all primarily urothelial.
And in the ones where it was transferred to pyroplasty, were there any cases with the lower pole vessel? No.
It was not even bicep or vessel in these patients.
Any other questions from the floor? Thank you.
Next presentation, robot-assisted retrograde plasty for repairing jugular obstruction in infant waiting less than 10 years. Where is Paulina Lopez, please?
Dear colleagues, as you know, preference of surgeon for pyeloplasty is most of the time transperitoneal and, if possible, robotic approach. But most of the studies explain that for retroperitoneal robotic approach, a weight is required of almost 12 kilos for sufficient working space for deployment of instrument. But in a center with a large experience of retroperitoneal laparoscopy, it's possible to decrease this weight to allow the small patient to access to this surgery. And here we are reporting a case of a 5-month-old children weighing 7.1 kilos who underwent this surgery. This patient had a UPGO with an anterior-posterior diameter of pelvis of 40 millimeters. And here is the surgical technique, and we modified trocar position to offer enough space to work. So there is 3 robotic ports and a 3 millimeters accessory port to the surgery. Total duration of the surgery was 200 minutes and consult time 140 minutes. There is a drainage with blue stent, and the patient was discharged on day 1. There is no intra or postoperative complications, so that we can say that we can decrease the weight of children to proceed to the surgery.
Thank you, Dr. Question on the floor? Professor Bennett.
Very fast. The port of 10 millimeters is Da Vinci robot.
10 millimeters or 8?
No, 8. 8 is a robot, and we use an accessory port of 3 millimeters.
Okay. Thank you, Dr.
So we move on to the next presentation. Laparoscopic lateral ureterocalicostomy for complicated uretero-pelvic junction obstruction in a girl in front of the lower vulva.
Good morning. I present the case of a 13-year-old girl with asymptomatic uretero-pelvic junction obstruction. According to a protocol, a retrograde high-pressure balloon dilatation was performed with no complication. However, she came back 4 months later with lumbar pain and clinical deterioration. CT scan showed an intravenous pelvis with very dilated lower port hallux and parenchyma thinning, so an emergency nephrostomy was placed. After recovery, a laparoscopic lateral ureterocalicostomy was performed. Through a transperitoneal fluorourethric access, the thinning portion of the lower port hallux was identified and incised, and also an longitudinal incision was done in the proximal ureter. Then a tension-free anastomosis between both structures was done, leaving a double-J catheter for 4 weeks. The patient was discharged in 48 hours, and 3 years later, she remains asymptomatic with ultrasound improvement and renal function preservation. So, in conclusion, laparoscopic lateral ureterocalicostomy is a safe and effective alternative in complicated ureteropelvic junction obstruction, and preoperative study is necessary to choose the best surgical approach. Thank you.
Any questions?
I can say, okay, congratulations on that presentation. So, looking at that case, did you never think about retroperitoneal chest? Because for the vascular pellicor in the pelvic system, if you go from back, it is easier to do perivascular or any other anastomosis. So, trans, you have to deal with the vascular pellicors. So, any experience about retro?
Yes, we have experience in retroperitoneal approach, but in this case, since the lower port hallux was so dilated, we thought that it would be better transperitoneal due to a matter of room, to make sure that we will have enough room.
I agree. Thank you. So we move on. Presentation. Video-assisted retroperitoneal ureterostomy as an alternative for patients with obstructive renal deprivation. Presented through Alfonso. Please.
Thank you very much. Well, we want to present the case of a 19-month-old girl which had repeated PL in previous episodes, and when studied we found a rapid ring ureteral system which had a complete duplication. The upper moiety had a ureteral hydronephrosis with a preserved function, and it drained intrasphincterally at the bladder neck. The in reflux or dilatation. In order to preserve the upper moiety function and resolve the obstruction, we perform a video-assisted ureter response. Regarding the surgical procedure, first of all, we perform a cystoscopy. We identify the ectopic ureter, which was intrasphincteric. We put a double-J catheter in the orthotopic ureter, and after that, we do a single port transumbilical laparoscopy. We identified the upper moiety ureter, which was highly dilated, and to a modified gypsum incision and an extraperitoneal dissection of the ureters, we perform an sterilization and an endocyte anastomosis. The patient all favorably and we resolve. We think this is a simple, minimally invasive, and a safe surgical alternative in these kind of patients which have upper moiety preserved renal function. Thank you very much.
Thank you. Somebody? Professor Tirante.
Thank you for the presentation. I think it is a good compromise if you find sometimes if you want to do any nephrectomy, you can do it. For example, sometimes it's happened because it's content in a kidney, you can do this because it's more difficult. We have several cases, you can do either we do intracorporeal or extracorporeal genostomas. A good solution, I think, if you have a problem during the operation.
Thank you.
Thank you very much. So we move on to the next poster. Laparoscopic nephrectomy for a case of Wilms tumor from Dr. Jaya Kumar in India.
Good morning, everyone. Greetings from India. My patient is a 3-year-old girl who presented with cramping abdomen. On examination, she was in a good general condition with no syndromic features, and the lump was palpable on the right side. CT scan showed mass arising from the right kidney with the tumor thrombus in inferior vena cava. Usually we follow close protocol for the renal tumors, but since this case was deemed inoperative, we give a preoperative chemotherapy, 6 cycles of DD-4A regimen, and the tumor was responsive. We performed 3-port 5 mm laparoscopic surgery. These steps were standard by reflecting the right colon, vesical apparatus, ligated the vessels, delivered the kidney to a financial incision along with lymph node samples. Post-operatively, we started the feeds on the same day, and further, the histology was reported as a favorable type with no tumor in the lymph nodes. She underwent flank radiation therapy and adjuvant chemotherapy, and since then 4 years, the patient had no relapse. Coming to challenges of laparoscopic nephrectomy for Wilms tumor, the challenges lie in the dissection of the tumor, handling of the tumor without rupture and delivering it, and adequate lymph node sampling. To conclude, with proper case selection, laparoscopy is a valid alternative for open surgery in Wilms tumor.
Thank you.
Thank you very much for this nice case. I just want to make very clear that I see a place for laparoscopy for Wilms tumors or oncology in general, but the umbrella study of this year has made very clear when to use laparoscopic approach for Wilms tumors and when not. So it can be a case-to-case decision by the individual surgeon. There are clear definitions on when to go for laparoscopy and when not.
Sorry, I missed it. Did you have a tumor extended into the vena cava?
Yeah. So the response after chemotherapy.
Sorry?
After chemotherapy, the thrombus had subsided.
Yeah. Thrombus in vena cava is absolutely contraindicated for laparoscopy. Thank you. Some progress are making with NEST-22 to improve the injection technique on intrarechial volume toxin. Dr. Montero.
Thank you. Well, we want to share this technical detail that we have improved trial two patients in our department. By means of cystoscopic bladder marking, we have performed some injections in the midline of the bladder in order to guide the intravesical botulinum toxin injection. We always start above the trachea and we perform in 1 centimeter interval, and we believe it's a useful resource to divide the injection of botulinum toxin. Here you have some cystoscopic depictions. The first one is a trabeculated layer in which the submucosal marking is applied. There's always a little withdrawal on a little leak on the withdrawal, but it resolves just in a few seconds. And after that, there's in the midline that it's clear marker in the above left, and we use that as a guide in order to apply it. We think it's a useful and safe resource which can be considered in this kind of procedure. Thank you very much.
Question from the audience?
Yes.
Why do you need that? Actually, if you apply that, you mean plurally visions. So, actually, I would prefer to do that. Just go rapidly and inject the botulinum.
Thank you for the question. Well, I believe it has several useful applies. First of all, when we are training or for experienced surgeons, probably it's easy to distribute equally the appliance of the toxin botulinum. But I think that as a training resource, or in complex cases, highly trabeculated, it can be a resource.
Thank you very much. So we move on. The next poster comes from Dr. Isabel Bosch, Endourological Management of Ectopic Urology, our last 15 years experience.
Thank you. Well, I would like to present our experience with endourological management of ectopic urology. The protocol in our center starts directly by treating them all urologically. If no reflux is observed after the surgery, we just control the patient. If we observe reflux, it is treated endoscopically up to 2 times, and if it persists, then we go to conventional surgery. In 15 years, we've treated 40 patients, 80% of them under the age of 6 months. All of them were performing day surgery. We observed no complications, and just one of them needed a second puncture due to this persistent obstruction. Of our 40 patients, 11 were cured with just one procedure, 13 with just one stain, and 15 patients required a second stain, which was effective in 6. Finally, 3 patients required a rectal implantation, and 6 patients required a hemianopectomy or an nephrectomy. In conclusion, we can conclude that endourological management of ectopic urology is a feasible technique in experienced hands, and although aspirative reflux is frequent, we can treat it endoscopically, leading, and we need, finally, bladder surgery. It can be postponed outside the neonatal period. Therefore, we have a less invasive ureter, and the surgery is simpler and with a bigger patient.
I agree with this kind of approach.
Thank you.
Isabel Bosch, again? No problem. Laparoscopic vesiculectomy in children for treatment of xenotria, please.
Excuse me. Well, we would like also to present our experience with laparoscopic vesiculectomy in Sener syndrome patients. This syndrome consists of a mesenteric duct anomaly that has 3 items: renal dysplasia or agenesis, seminal cystic vesicle dilatation, and ejaculatory duct obstruction. We present 2 patients with this syndrome, both with associated ectopic ureters, in which we performed the vesiculectomy. One of them was asymptomatic, and the other one had a repetitive bronchitis. The surgery is, and we proceeded to put 3 trocars, a 10mm trocar, a 10mm trocar in the miltus and 2 5mm trocars in both iliac fossa. We open the vesical peritoneum and dissect all the important structures, the vas deferens, the seminal vesicles, and the ectopic ureter. and then with vessel sealing devices, we resect the top ureters and the seminal vesicles. The mean operative time was 150 minutes with a mean postoperative stay of 2.5 days, and after an 8.5 year follow-up, none of the patients have presented recurrence complications or another ultrasound seminal vesicles dilated or another cystic lesions. So due to the low morbidity of this procedure, we support surgical management of Sener syndrome in these patients to avoid the heart complications they can have in adulthood.
Any questions?
Sorry. If anyone, otherwise, the congregation is open. I agree with you, of course, just a point. Sometimes we have to operate because they're symptomatic. Sometimes the cystic lesion is so big that it's not easy to save the contralateral ducts to avoid sterility. So, which is your recommendation for avoid to injury the other side, normal side?
It's quite hard in these cases to avoid damage to the other side, but the problem is that even if we don't operate this patient, it has been reported infertility because of contralateral damage just because of the cystic dilatation. So even if we don't operate them, the contralateral side is sometimes already damaged.
So we have to inform the advice.
We have to try to save the other side, and if we don't save it, it was probably already lost.
We have to inform parents before surgery.
Yes, that's important.
So we have another talk on this topic, laparoscopic seminal cyst excision in an adolescent with Sener syndrome, from Dr. Catalina Carvalho.
Good morning. Sorry for the small size. It's not so clear. So I'm going to talk about another case of a patient with Sener syndrome. As we know, congenital vesicle stenosis are extremely rare conditions, and even more rare when accompanied with renal malformation. So I present to you a case of a 13-year-old adolescent male that was sent to our department for a recurrence of reproductive pain, in which the study identified a right cystic lesion. The MRI and the CT scan were performed, and the right renal agenesis was identified together with a multilobular cystic pelvic lesion. So we conducted a laparoscopic exploration. 4 or 5 millimeter strokers were used, and a right seminal cyst was identified. Due to indissociability from the right vas deferens, was actually necessary for complete lesion excision after contralateral vas deferens inspection for microscopic normality. Total operative time was 140 minutes. No intraoperative or postoperative complications were identified, and the patient remains asymptomatic after 8 months of follow-up. So in our opinion, laparoscopic is a safe option to treat these patients, but given the possible involvement of the vas deferens, it's important to inspect the contralateral side before conducting this kind of procedure.
Thank you very much. Questions?
No. Thank you, Dr. Dr. Luciano San Giorgio from Alessandria. Federico Leoni. Okay. Ectopic prostatic tissue in Bulgaria with penetration in pediatric patient. Endoscopic radiology treatment against the board. Please, Dr. Leoni.
Hi, everybody. This is the case of pediatric surgery unit in Alessandria, Italy. It was a case of ectopic prostatic tissue in a bulbar urethra and depression for review of the literature. So the case report, it was 15 years old, boy, with bladder and splenomegaly. It was noticed at 2 months of ultrasound, and an history of dysuria, a low urinary obstruction symptom in the last 5 years, and hematuria in the last 1 year. Moreover, it presented recurrent fever, and so the splenomegaly analgesic analysis was performed and came out LPNP At the cystolithoscopy was administered, so it was noticed around this chronic and fully obstructing lesion of 10 for 9 for millimeter, with the distal, very distal portion of the nerve montanum, that in the context of chronic urethritis with the white cords around the levator. And so it was a complete exeresis in the intercalculation of the polypens, the base, for recanalization. And the pathological investigation was an ectopic prostate tissue consisting in a prostatic gland. Then a genetic capture for 3 weeks and antibiotic therapy for 3 months for the urethritis, and the symptoms were returned over 2 years follow-up. So the discussion was around the prostate appears 12 weeks of gestation, so it was a left of migration, probably, of the prostatic tissue. And the radical is due to the risk of malignancy degeneration, because the reported cases of prostatic adenocarcinoma was in the topical tissue in adult patients. For the investigation must be done for the relation with the splenomegaly and the fever and the germ that was cannot with the investigation. Thank you.
Thank you very much. Very nice presentation. Yes, please, there is a question.
If it is a polyp and it's size, why do you need 3 weeks catheter and 3 months antibiotic treatment?
Yeah, antibiotic treatment for 3 months because it was there was an urethritis, so the bacterium for the eradication, we have decided to do 3 months at least.
Thank you, Dr.
So we move on to the next presentation, cystoscopy guided robotic approach of prostatic urethritis, case report and review of the literature from Dr. Fatih Frederica.
Good morning, everyone. I will present a case of a 2-year-old man with a diagnosis at birth of DSB. We present an incidental finding of prostatic urethral during the correction of penoscrotal hypospadia. The ECU showed the opening of prostatic urethral at the level of the velum montano above the bladder neck, so it was grade 2. We performed a cystoscopic guided robotic resection of the prostatic urethral due to several episodes of urinary infection. The advantages of this approach are the better anatomy visualization and the ability of moving in deep and restricted site. The contact traction movement permit a safe dissection, and the cystoscopy left in place permit to check the correct closure and the control of the urethral anatomy and the fast recovery and minor post-operative pain. Thank you.
Thank you. What about the difference? The last.
Inspection both difference was about in the prostatic urethral, so we dissected and.
I know, but how do you manage that?
For the procedure. And also he had testis, so.
What? Another question? Thank you. Dr. Abdul Jadid, laparoscopic microphone procedures with modified shunt-fight anastomosis, please.
Good morning. Microphone is a well-known form of continent catheterizable channel. We are presenting a case of laparoscopic microphone procedure. Our patient was a 16 years old girl with complex background. And she had large capacity bladder with deficit in unreactivity, high residual after avoiding, and failure of CIC training. So laparoscopic maternal procedure was performed using 3 pores. Few steps shown in the picture. A stomach was selected to right iliac fossa. A retrocerebral tunnel was made. Appendix was speculated and modified shunt anastomosis of appendix into bladder was created. The skin and appendicocutaneous stoma created in the right iliac fossa by double uretectomy. So post-abortic recovery was uneventful. The CIC through the mitral was commenced after 4 weeks after surgery, and it was working nicely. So laparoscopic mitral procedure significantly decreases the morbidity of surgery. The modified shunt anastomosis simplify the appendicovesicular procedure. Thank you.
Thank you. Question from Helen?
One question, would button vesicostomy also have been an option? A button vesicostomy also have been an option to start CAC?
It should be an option.
Thank you, Doctor.
So we move on to the next presentation, robotic bladder augmentation, our first case from Dr. Carmen Soto Borga.
Good morning. Bladder augmentation is the best option in patients with robotic bladder. We present a 12 years old child with several by minor instance. She had a very low bladder capacity, but one adequate sphincter closure. We used the Vinci system, XI, and the trocar was positioned, as you can see in this picture. All steps were done by this way, and the ileocystoplasty was completed in 6.53 hours. No postoperative, there weren't postoperative complications. And now she is dry with IC every 4 hours, and you can see this abdominal wall in this picture. I believe that the robotic approach is safe and easy in minimal invasive closures in complex surgeries. Thank you very much.
Any further questions?
I think that this will be the future.
Yes.
And we have a,
Thank you.
thank you. Dr. Beatriz Fernandez Bautista, endometrial implantation as a code of reverent hematuria.
Urological endometriosis is a rare pathology. The clinical manifestation are cyclical with pain and volume syndrome. However, cyclical hematuria only appears in 20% of cases. We present a 13-year-old patient with history of left nephrectomy for primary scrutiny ureter and repair of proton malformation with vaginal wound placement. A few years later, patient presented episodes of cyclical hematuria. We did a cystoscopy and found a lesion in the left urethral stump. Complete resection of the implant was carried out by cystoscopy with ulnar laser. As a result, no new episodes of hematuria recurrence were described. In conclusion, urinary tract endometriosis is a rare entity. His description is exceptional in urethral stents. It shall always be suspect in case of cyclical hematuria in adolescent girls with a prior history of genitourinary surgery. Endoscopic management is a minimally invasive alternative for this treatment with poor results in the patient presented. Thank you for your attention.
Thank you. No question?
consider, do you have any sign that there's any other extravertical problem? Did you do a laparoscopy or when necessary? What was your program?
We did a magnetic resonance that showed a superficial mass inside the bladder, and we decided to do an endoscopic pulmonary approach.
So, and the patient is symptom-free at the moment, or isn't there any pain?
Sorry?
The patient is without symptoms now, without pain?
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 If the patient has symptoms.
You still have pain? The patient still has pain?
No.
Dolores?
No. It's asymptomatic.
Okay.
Thank you, Doctor.
Thank you very much. So the next presentation is there a role for minimal access surgery trauma from Joseph Wiltshire from the UK.
Good morning. So I'd like to present two cases where we've used minimally invasive access surgery following complications in pediatric trauma. So the first case was an 8-year-old girl with blunt abdominal trauma following a road traffic collision. This was complicated after conservative management by a bowel leak. She had a stent placed and this unfortunately migrated. So she had a robotic assisted procedure to open the CBD and retrieve the stent. The second case was a 13-year-old child who had a grade 4 liver laceration, which was complicated by significant devascularization of the liver and a massive hematoma shown in the CT scan on the top left. This was then complicated by extreme difficulty in ventilating the child and getting her off of assisted ventilations. And she underwent a laparoscopic assisted procedure to evacuate the hematoma and the sloughed necrosed liver. Post-operatively, she quickly improved from a ventilatory point of view, and the chest x-rays demonstrated the massive difference that she had, and she x-rated relatively easily following this. So in conclusion, minimally access surgery should be considered as a method of treating children following trauma.
So in the second case, you...
Sorry, you asked
I'm sorry, I just wanted to ask, in the second case you performed laparoscopic diagnostic surgery due to the fact that the patient was intubated and could not be extubated.
Correct.
Yeah, thanks, Andrew. So just to go on to the basic message is that in severe liver trauma, just sit tight, don't go in. You can deal with the complications later on, that's the safest way. And you can deal with the complications laparoscopically or clear open, but the same thing is not required with both of these patients. The second one had embolization as well, but with both of these patients, the other person, they want you to go in and do something. But you sit tight, hold tight, just keep on transfusing, you cannot use it down and you can save the child. Thanks.
Take a message, they see, they receive.
Okay, thank you. Bye.
Following the recommendation of our chairman, I have to thank Marta. Thank you very much for your very fine organization of this very important meeting. I know this is very hard responsibility for you to check everything. Everything must go ahead and work. So we will go ahead. We start our roundtable. I ask my presentation for the introduction just there. And yeah. Yes. This is not mine. Okay. Don't worry. So, very nice roundtable on a topic which is changing very quickly in the last few years. If I compare what happened in the last 15, 20 years, that is very, very modified. And so I know nothing to discuss. So, as we know, goals of stone treatment children is to achieve complete clearance by minimally or not invasive single procedure, which is not easy, and avoid open surgery. But so recently, quick evolution of technology and of procedures have been seen. So where are we now? We would like to focus where we can do what we are doing, which are the new things that are arriving with some experts. So consider that we have 3 different ways to reach the stone. Direct renal percutaneous chest, by mini or micro pack, retrograde retinal access, whether or little biopsy or retrograde intrarenal surgery or a new step, flexible laparoscopy surgery. We could combine the two, and then also the laparoscopic chest with trans or retrograde way. So this roundtable, we have Adam Maliski from Poland, Stefania Ferretti from Modena, and Mario Bucci from Vicenza. We could discuss the new things for children treatment, but I will give you some little tips. So some new tools are arriving. For example, balloon dilation is safer in our experience and less bloody. We recommend that, less traumatic. And we use now the Trilogy Lithoplast, which is combined ballistic ultrasound energy with aspiration, which gives very nice results and a beautiful view for the scopic treatment. We do prefer now the mini bag for many procedures. This is our equipment. And we do use the clear filter system, which is a new one, which has the facility to attract the little stones and the power, and to increase the visibility during our procedure, and with laser as well. And we do like thallium laser, and for retrograde ureteroscopy, we like the new flexible ureteroscopy with the new sheet. The new sheet, very nice in the SEO, also a bit costly. The point is the cost of this kind of procedures. So, finishing my introduction, I have to give you some messages. Which stone I deal with? We must look in pediatric metabolic nephrological study. We have several metabolic stones, cystine, lactobacillus. We have to study this kind of stone that we have. How uterine and piedocalcium neurological anatomy is never go without the study of anatomy. So we have to study preoperatively the anatomy of the kidney and the urinary tract. Which is the best way to reach the stone? So we have to design our most efficient embryological strategy. If I have an expert event, so consider before starting a possible second extra way. What can I need? Prepare all the necessary instrumentation guide-wise. Prefer flexible endoscope when it's possible. And so be always soft and flexible in embryology, never traumatic. Smaller endoscope is still scary. Sometimes I don't think it's really better. So sometimes I have to stop for the small cannula. Have a good vision. Not drive blind. Never blind. So, seems to be stupid, but it's not so stupid. Avoid high pressure inside the tract. Respect the airline clima, especially in younger infants and children. And then the last 10, do not force any maneuver. Be soft and smooth. The urologist must adapt to the calcium system and not the company. Finally, what else? How many recommendations? How boring I am. Achieve stone status if possible. Second, the endoscopy could be wide sometimes. Don't be extensive. Avoid open surgery. Don't be unhappy. Keep calm and patience. Be picky and dedicated. These are my tips how to manage it. Whatever you want to do. Anyway, so this is our roundtable of new technologies, changing these, but these principles I think must be stable in our minds. So thank you. I think I finished my presentation. Because I was looking the history of the endoscopy. I didn't remember open Bivar in effect with. So, please, Adam Pansky is coming from Poland. He will present new tools.
I would like to thank you, Marta, and the organizing committee for inviting us. If I can have my presentation, I'm already connected.
So my recommendation would be probably I think that we have to move my hands always after moving the brain, and not vice versa. Okay. Thank you, Lucas. Innovations are so quickly arriving that we have no time to adapt our technical movements to the new things that are arriving. This is for all, for laparoscopy, for endoscopic treatment, from well, any trouble? Because time is random.
Just a technical.
Do you prefer to start with the second presentation, then you try to set up your PC?
El computador que no detecta
How many of you do you perform normally with retrograde or percutaneous hyperprostose? I think it's not so common in pediatric surgery units to do such kind of surgery. How many do stone treatment with scolpoloscopy? Can I ask you, it's not so many. Yeah. Because we need some connection with the adult neurology. Absolutely. Technical equipment for increasing our capacity. But could we go to Marta, you think I will go with the other one?
Yes, sure. But the problem is the same. No.
Because we missed the acknowledge to start the we can.
Okay.
We can go ahead and read Stefania presentation.
Podemos saltarnos así a sus speaker.
Yeah, Stefania, I read almost.
Stefania Ferrer.
I read to Stefania, which is my friend adult urologist. She's doing pediatric urology as well from Modena University. She's very clever for all the endoscopic procedures. So I have to thank her for coming here to give her experience in the treatment in difficult cases. Thank you, Stefania.
Thank you, Paolo. It's a pleasure. I'm very happy to be here in another kind of world. And speak to you about PCNL and percutaneous approach, combined percutaneous approach in children. When we look to the indication are the same as in adults, also in children for PCN approach, and of course for the stones much more than 2 centimeters, or sometimes also smaller if there's no possibility to perform a shockwave lithotripsy or recurrence after shockwave or after ureteroscopy treatment. And as you can see, the stone-free rate are very high, between 71 and 95%. Also, the complication rate is not low, but if you look at this complication, you see that they are lower than 1-2 Clavien-Dindo classification. So it's not a big problem. And today, the miniaturization of the instrument, as Paolo said before, help us to perform also percutaneous in very complex cases with minimal approach, percutaneous approach. As you can see also in the guideline, the percutaneous is indicating in Stegon stone calculus, the pelvic stone 1 than more than 2 centimeters, also in combination with the lower calyx, and sometimes also for stones of 1 centimeter and more, because sometimes there is a problem of malformation, of difficult to the expulsion of the fragment after, for example, a shockwave lithotripsy. And there is a literature about the importance of the percutaneous approach with respect, for example, to the retrograde intravenous surgery for, of course, the same stone burden, and also the possibility to, also when we look to the lower calyx in combination with pelvic calyceal stone, the mini PNL approach has a higher stone-free rate in the first section, and so there's literature who say that it's better to perform mini PNL than, for example, shockwave lithotripsy in several sections, and so on. There's also literature about the stone management in Stegon calculus. There is literature in favor of the percutaneous approach, and also the important post-op complications like bleeding, they are very low, less than 5%. And we know very well that the bleeding, the risk of bleeding is directed to the number of tract size and the size of the tract, of percutaneous tract. This is the same in the adults. This is a very important paper that confirms that the stone, the size of the percutaneous is directly correlation to the risk of bleeding. So, how to perform in pediatric PNL approach. As you can see, we have to have minimal invasiveness, number of narcosis, minimize the X-ray exposure, and if it's possible, of course, if possible, high stone clearance. And today, as Paolo said before, we have run through the miniaturization also in our society, the miniaturization of instruments, and also in endourology, this is the must. And today we know that it's important to choose the correct access, percutaneous access, respect the endocalicial anatomy, the clearance, the compliance of the calyx, and also respect to the stone button. So this is the possibility to use, this is the instrument that I use in adults, and it's the same that I use in children, because today the possibility to reduce the time of lithotripsy, as Paolo said before, with the new generation of combined ultrasound and ballistic source, but today especially the new laser, we have the high potency onion laser, and in particular the super pulse thulium laser. This is a revolutionary, the approach to dusting also a very large stones. And of course, this is the remarks when we approach the percutaneous in a baby. And of course, when it's possible, I prefer to perform a combined surgery with the retrograde access, so-called endoscopic combined intrarenal surgery, ECHIRS, because there are a lot of advantages. This is the position. We changed our approach to prone to supine in 2008 in adults, and of course also in children. Even if we know that there is no difference in the superiority of one technique to the other, but also in our experience is so. But we fall in love with supine approach here in Spain in 2008 with the experience with Professor Valdivia Uria in Zaragoza and Professor Ibarlucea, Gaspar Ibarlucea in Bilbao. They was our inspirator to supine approach. The advantages in supine are a lot, as you can see, better respiratory, reduce the surgical time, especially in adults. In children, it's very quickly to move the patient from prone to supine or vice versa, but the possibility to see, as you can see in this immediately, the possibility to see the puncture in the endovision approach is very important, because we know that we are in the correct access transpapilla and not, for example, transingular, and so we reduce the risk of bleeding after the procedure. Of course, supine and combine have some disadvantages, because when we when we work in supine, the collective system is empty, but this is an advantage because the fragments go out spontaneously, for example. Of course, we have two equips, two nurses, two equipment, and sometimes also some problem in economy approach, but I think that is very important. I want to show you this video that you can find in Videourology, the Journal of Endourology. It's not recently, it's about 10 years ago, but it's very didactic. This is a little baby, little girl of 2.5 years, presented. And today we perform the same approach as 10 years ago. The different, of course, as I said before, we have more choice in miniaturization approach. This is they remove the presented patient, and then we put an access sheet, 9.5 urethral access sheet, and then we go up with the endoscopic, flexible endoscopic, we see the stones, and now we choose the correct papilla and calyx. In our school, we perform only an X-ray percutaneous puncture in 0 and 30 degrees. We don't use generally the ultrasound approach, even in a particular case, but when the baby is on the table, we perform ever check an ultrasound to see the viscera and so on. Then, if you look to the endoscopic, we see the correct percutaneous access in the center of the papilla, and in this way, of course, this is a didactic video, and so we see also the X-ray, but generally you can follow all the percutaneous with only the endoscopic guide, so reduce a lot the X-ray exposure that in children is very important. At the same time, when we start to fragment the stones, if there are some pieces go up to the superior calyx or in the inferior calyx and so on, the possibility to check via retrograde with flexible and catch with a basket this fragment, so-called pass the ball technique, because I take the fragment and I put the fragment in front of the percutaneous axis, and then the colleague take and follow out the fragment. Also the possibility to inject the water from below to up, it allow the clearance, spontaneous clearance through the access sheets, and the possibility also to perform a tubeless procedure at the end, not in this case. In this case, we prefer to put just a little 12 French catheter, but generally they are a tubeless procedure. So I run at the end of my presentation, so we are in time. And the take-home message are that also in childhood, PNL is the gold standard for the stone than more than 2 centimeters. And today, laser technology improvement allow fast, safe, and efficient mini PNL approach. Thank you very much for your attention.
Thank you, Stefania. We go ahead. If you are ready, others. So, thank you for so you see how difficult sometimes it is to have all the materials. Technology is almost complex in this case.
Yeah. Thank you so much once again for inviting us and inviting me. I would like to thank the organizing committee, the chairman. My topic was the ureteronoscopy and retrograde intraoral surgery in the third millennium. I have no disclosures. This is the agenda of my presentation. Then we'll speak a little bit how we change our mind. We'll go through the laser stents, efficacy about the neurooptical procedures, equipment, what we can expect and what we can improve even from today, and then we'll let me conclude. So first of all, we change our mind. It used to be that we had a surgery, or even most of the open surgery. Then in the 1980s, we got the ESWO, which we could put wherever we want. But according to the data, we are not allowed to perform the ESWO in the lower part of the ureter. And nowadays, the ESWO is stepping a little bit back, and the surgical procedures are going a little bit up. We have we can perform the flexible now. In the middle part of the ureter, we have both the ureteronoscopy and ESWO. And as I told you before, we are not allowed to perform the ESWO in the lower part of the ureter, and this is also in the EU guidelines. Right now, the ESWO and flexible ureteronoscopy are on the same However, in children we still have a very good efficacy of ESWL, so rather ESWL is the first option. Laser. We are all saying laser, but this is an acronym. This is the light amplification by stimulated emission of radiation. And we have started in the era of the 15 volts laser, then we go for the 30, 70. Right now we have the very powerful device which is 150 watt quanta cellular only laser. And the laser settings, you can, at the menu, you could have so many options to choose from the soft tissue, the leakage or lithotripsy. And according to the two pedals that you have, you can use on the left, for example, fragmentation, and on the right, you can use popcorning, dusting, whatever you want. You are not losing the time to change the settings. However, there are so many settings in the lasers, so this device increases our possibility under your logical procedures. You can adjust the settings to your stone. You can increase the energy, increase or decrease the frequency. At the same time, you can do it with the dusting, corning, fragmentation, whatever you want. However, laser settings and laser warnings, remember that you still have the regulation. There is still radiation, so you should use protective glasses. And remember that with new devices, the time of the procedure is shorter. But remember about the temperature of the water. Put your hand under the output channel and check the water, because when you are involved in the surgery, you are so happy that you can laser the stone. But remember about the temperature. This is very important, especially with the new high-power devices. Laser was a game changer, and it's still a game changer, I think. And we are expecting new devices which will decrease the time of the surgery, which will increase our efficacy. Of course, we can still use the old devices, but why not to drive something better? And stents, ureteral access sheet, guide wires, there are still many new companies which are producing new stents names, new ureteral access sheet names, guide wires, and so on. They are decreasing the sizes of it, but we still have the old problem, especially with the stents, which is an incrustation. You can see here the scanning electron microscope. Even after the second day, we have an incrustation. This is a very important topic. This is on which we are working right now with my bioengineering department. Try to avoid the incrustation, and also the biofilm is also, and then the UTI is also a problem with stents. So if we can find something, this could be also the second game changer. Endourological procedures in the retrograde and the ureteronoscopy, according to the worldwide literature, is still rising. Where are the reasons? The reasons are like the stone disease. It's multifactorial, so we are performing much more surgery. So if we're doing some more surgery, we are better. We have the better equipment, the better view, and this is the reason why the efficacy is still growing, and that's really very good information. Equipment. So we, as my friend Paolo said, miniaturizing is not always the best, but in rears or ureteronoscopy, it helps us to perform the surgery even in a small child. We are going rather to the single-use scopes with a good view. Right now, the Hulk we have a very good view, and the price is much lower than the reusable. And where are the game changers for rears? Maybe we also starting with robotics, and we will see what will happen then. Our expectations in the coordinate. So the equipment, reusable, single-use with a good view, more stents, but without the problem of incrustation and the biofilm. Equipment which will measure the pressure, which is very important, especially in children. We need to have reference center, alarm protocol to achieve the goal and to lower the radiation dosage. Also the faster diagnostic process and cooperation between urologists, and those last two are here because if you have a fast diagnosis good cooperation, you could have easy procedure, easy. Not so easy, but not so difficult. You can achieve the stone, you can make fragmentation or testing, but if you will have the long-lasting process of diagnosis, you will have the situation like you will have here on the right, like the stone which was ingrown in the ureteral orifice. On here, as you will see in a few minutes, as you can see here, we have the stone ingrown, and this is the game changer. If we won't have a laser, we will not be able to do the surgery. We have to go for the lab or in the past to the open. And here on the right, you will see the edema of the ureter. This stone was in the ureter up to 7 months. So the child weighed 7 months with the stone like that, with the edema of the wall. And after such a time, after surgery, all we will have, of course, the stone create hard, but there's a high possibility of the stricture. So be fast as possible. What we can improve today? So we can increase our knowledge and skills. We can decrease the number of procedures, avoid some ESWL sessions, go for the urology. This is the third millennium. You can go to the hybrid operating theater when you have a possibility to perform all the procedures at the same time. We have the good cooperation with cardiological departments where they allow us to go there. We need to standardize the procedure. So before you put the ureteral access sheet, make ureteroscopy. Be sure that there is no stone, and you will not have a problem when you put the ureteral access sheet into the patient. This is one of the follow the rules, as Paulo said. Never force. Be gentle. If you have a problem, put the DJ stand. This is also the third millennium, and this is smart and nice move to be gentle and polite. This fluoroscopy on such an operating theater is very good for us because you can narrow the band of the radiation, and you can just make a fluoroscopy only of the kidney. This is very important. And as I told you before, here you have the ureteroscopy before the ureteral access sheet, and there is a stone in the ureter. Decrease the radiation dose according to this possibility of the radiation, and create the stone centers with the stone feeding like pediatric nephrologists, urologists, dietitians, nurses. This is the goal of the third millennium. So in conclusions, the laser devices increase and extend our possibility of endoscopic treatment. There is the constant progress, and then the urology devices and utilization help us in performing ureteroscopy in a very small child, and follow the urological rules and be safe with this. Remember that you have also the possibility of the DJ stent and to come back for the surgery. So just thank you so much.
So difficulties, new technology, new devices, more experience with it. You present, please. Thank you for your welcome.
Okay, good morning to everybody. I'm very honored to be here, and I'd like to thank the organization for this great opportunity. So, my difficult role is to speak about the transfer retroperitoneal approach and the indication and the limits of this surgical approach. We are here because the lithias in pediatric population are increasing in the last year. It's very important to treat, and in the previous report we have seen what can we do in our endourological technique. And my role is to identify the situation when minimal invasive surgery, trans or retroperitoneal approach can help us to treat this complex pathology. We don't remember that the treatment of the kidney stone in pediatric ages cannot be improvised, but requires a perfect knowledge of the all available technique in a center that takes care of this patient. So, when we consider the minimal invasive surgery, obviously not in the previous instance, not in the initial instance, we can consider it when the urological techniques are not adequate in pediatric population. And when it happens, when the baby is very small, they have a very low weight, when we have a large and impact pelvis and large ureteral stones, or especially in a little child, when the lithiasis is in conjunction with anatomical anomaly of the urinary tract, like also spinning on duplex system, and when we have a complex stone, when we need a lot of multiple treatment endoscopic, and when we are in the synchronous UPJ obstruction, and when the endological technical failed. So, in this report, the EU guidelines of 2006 can help us and to identify the indication of the laparoscopy and surgery in case when the endoscopic technical failed and the call-out impact stone in the high road, the minimal invasive surgery. So in literature, it's not very definite indication of the approach that we can choose. We know that the approach available are the transperitoneal approach and the retroperitoneoscopic approach. So our experience in many years of practice, in many cases of practice, can identify obviously the specific characteristics of this technique. About transperitoneal approach, it's a more spreading technique. We can have a very good surgical space. It can be an easier approach. Can we have a good exposure? Yes, but we have to need to mobilization the intestinal wall. About the retroperitoneoscopic approach, it's very important to have a very good experience in this space, in this retroperitoneal space. It is a physiological awareness space, and we don't need the intestinal mobilization. So, which approach to choose? The experience about these two approaches can allow us to identify a situation in which we can choose one or the other approach. About retroperitoneal approach, we prefer to use this approach in large stone or complex stone of the pelvic situation, especially when the pelvis is very small, and this can happen in lithiasis. This approach, this choose, is because we have with the retroperitoneal approach a direct access to pelvis, avoiding the vascular hilus. So we can opening with very greatness the pelvis, which don't touch the hilus vessel, and this is very necessary to remove a very big stone. We prefer the transperitoneal approach when the lithiasis is in conjunction with the ureteral-pelvic junction obstruction, with the hydronephrosis, because we think that it is necessary that pyeloplasty is easier with this approach, and we use the transperitoneal approach in ureteral lithiasis. In this particular case, with multiple site lithiasis and ureteral lithiasis, the expungement are to properly plain surgery, because the transperitoneal approach allows visualization of all the ureter, but in the retroperitoneoscopic approach, we are limited access to ureter tract under UP injection. So I show you some examples, some complex examples that you can think about minimal invasive surgery, a young child with a metabolic lithiasis, and another child with an anatomical anomaly, in a situation with obstruction and necrosis, and in recurrence after endurologic technique. So I show you the video about these two approaches. The first one is the transperitoneal laparoscopic periolytotomy. You can say that the first thing that we have to do is to mobilize the pelvic flexure to have access to the kidney and to the pelvis. So with the sealing, we can open the renal space, because we have to have a very good exposure and a very good space to maneuver, to open the pelvis. As you can see, as I explained before, in laparoscopic transperitoneal approach, we find the vessel in front of us. We can isolate the ureteral tract, and then we can open the pelvis. We can touch with the instrument the calculus, and we can open it directly where it is, and then we can remove it. Normally we can choose this approach when the calculus is very, very big. You can see that is so difficult because the calculi is very attached to the appendix. And it could be necessary making 2 or more times to remove definitely all of the utilities. Then we go to the suture, in continuous suture. Okay. I show you the retroperitoneal approach. In our school, we think the retroperitoneal approach are very exciting approach, but it needs a very big experience about this. I show you as Dr. Chiarenza opening the space and consider the essence of the retroperitoneal site. Okay, so dental, so under vision is important to identify the space. Okay. We put the other trocar, and there we go to exposure our side. So you can show. I would like to make your attention about the condition of the tissue that we find in laparoscopic and retroperitoneoscopic approach. When calculosis is present, the tissue are very inflammation. We can see now the opening the pelvis to identify the calculi that this was a cystinouric calculi. And then we remove and we perform the suture in the same model of the laparoscopic transperitoneal approach, but in retroperitoneoscopic it is more important to not mobilize the kidney, because if the kidney falls down, you can see anything. So it's important to don't mobilize the ring. So, what are the favorable aspects in minimally invasive surgery? I see that we can use it in a low age and a small way. We know that in some neurological techniques are difficult to make in very little patients and are not free from complications. We don't make any parenchymal trauma. We can control very well the bleeding risk, and if you have some complication, we have a very good vision of the situation. The technical aspects are very important, and the minimal invasive surgery in this situation is a very higher stone-free rate and is definitely treatment. We can consider it the minimal invasive surgery like one shot, one kill, but be careful, because we have to keep in mind that this patient that we're going to treat is a person based on a metabolic pathogenesis with a very high recurrence. Another very important aspect that I show you is we can resolution the underlying pathology, such as obstruction of the urethral junction with dismembered pyeloplastic or non-dismembered pyeloplastic for partial stem. But please don't remember, I show you the video that in this case the pelvis is very inflamed, the thickness of the suture are at high risk of leakage and the sequence anesthetic. So don't remember, it's a very demanding technique with a high complication risk. Another favorable technique we are speaking about the previous before, that the laparoscopic approach reduces significantly the radiologic exposure, that in patient pediatric population is a very important aspect. But we have some controversial aspects, some limitation of the minimally invasive surgery. Is minimal invasive approach, yes, but not so minimal. We always need to open the pelvis and to resuture. And what about complication? Suture leakage, so we need to drain in the most of cases. Well, what about follow-up? About suture stricture, our experience in endoscopic treatment show that the stenosis is also possible in the ureteroscopic treatment, but we don't have to. We have to remember that also in minimally invasive surgery this is possible. Another limitation I would like to keep in mind this very important aspect is that the population that we go to treat is a population with a very high recurrence of the lithiasis. So what can we do for the recurrence in chronic pathology? We can do a redo minimal invasive approach, or you have to change your approach. It's important to remember that the minimal invasive approach don't preclude any other any urological technique if the reference occurs. So, as I said, Dr. Tagliani speaking yesterday about this, the role of the minimally invasive surgery in the urinary leakage tract is a little battle. When we decide to choose this approach, we have to ask ourselves a good question. Who is the patient who can operate with this technique? We need to have a very accurate impacted selection when we have to know if there is any pathological metabolic situation, if the patient has a previous procedure, and what the experience is very important to choose laparoscopic, transperitoneal, or retroperitoneal approach. In conclusion, the minimally invasive surgery is not the first choice, or only in a very little population, but in a selected patient it can be a very reasonable and safe minimally invasive option in pediatric population. Now, I hope that some take-home message about when minimally invasive surgery becomes a very good choice or the first choice when endoscopic techniques are inappropriate for children based upon age and weight, whether we found a very large stone, when we have stoning anomalies of the urinary tract, when the stones are very complex and require a lot of treatment with endoscopic technique, and when the endoscopic technique are failed. It's important to remember that the minimally invasive surgery requires experience, and we can use the unique technique or in combination with the other technique. Together, I think we will. So thank you so much for your attention.
I have to congratulate with all the speakers because we have all time and we have time for some discussion. I give you this, Adam, to moderate and to do conclusion and discussion for the audience.
It's working. Do we have any questions from the audience?
Well, short.
Come on, are we sure we have a question?
Dr. Peretti, very nice. Congratulations, all of you, because we cover all the technique, minimal invasive technique in pediatric urology for the stones. Very happy with this. I like it more a lot, the combination in between the ureteroscope and mini-TERT or TERT what you do. What is the limit of age that you have to treat the patient for tuberculosis with combination? Because the limit also in flexible.
Yes.
Ureteroscope.
Yes. Generally, you need, for example, the presenting patient up to 3 years. Up to 3 years is the limit for combine, and it's better between 3 and 5 years after presented procedure, because if you want to put an urethral laser sheet, it's better, but it's not mandatory, because you can go half without urethral laser sheet to combine. Today we have a very important scenario of disposable, flexible ureteroscope. For example, we have a 7.5, and I can say the manufacturer because it's exclusive and is by Usen. Usen 7.5 digital flexible ureteroscopy is the smaller one on market. And of course, today there is a very run for this disposable instrumentation.
And to add, what caution do you use during the laser fermentation? I mean, I saw that you put a shield. How do you measure the pressure? Yesterday we saw a very nice presentation of our colleague for the operation in kidney. do you use some tricks, tips and tricks to check what happened for the warming and also to the pressure?
Yeah, that's the real problem, how to assess this situation. We don't have a specialized equipment. During the workshop, I said that there is the pressure measurement possibilities. I think that we should introduce it in all of our endoscopical procedures. And the laser, we try to not to exceed in kidney the 24 watts, and in the bladder the 32 watts. This is the maximum. For example, what the laser company told us that we cannot exceed, so we are not allowed to exceed those limits.
Simona from Turin. Thanks for all the speakers for the beautiful presentation. Just two strategic questions. According to the guidelines, the choice is still very complex, but according to the guidelines, stones below 2 centimeters first attempted by the SWL. So is there still room for the SWL for pediatric stones, or we are moving more towards endoscopic treatment? And the second question is, probably over the past years, we actually moved from SWL to intrarenal surgery, but for complex stones, should we prefer PCNL instead of repeated intrarenal surgery?
Although the literature and experience, the SWL are very high recurrence. So the limit is very in the pediatric population. The treatment, we can make a lot of treatment, and when we choose the technique, we have to remind that it's very important to have a very high twin stones. So in this case, if it is possible to have an endourological technique, I think that is better, because the high free rate is the definition of the technique are very high at the other Haswell.
We are performing around 120 cases in the SWL every year, and that there is still place for it, especially according to the literature in our experience, the younger children has the greater chance of success in EWL. So if you have a small child, even with a big stone, it won't be a problem. And those child are moving so much, so the spontaneous passing the fragments is not a problem for them.
Yes, I think that the shock wave is not high, but there is, for example, in our reality, we have not a pediatric surgery unit. So the baby need to come to our institute in the adults. And for example, I think that there is a balance between the number of shockwave sections, the number of narcosis, and so on. So if you want to have a stone-free rate, a very high stone-free rate in one session, sometimes for stone more than 2 centimeters, it's not possible to think to shockwave. I believe in this. Of course, I'm not a pediatric surgery. And today, for example, for answer to your question, what about 2 centimeters, for example, a cutoff? Today, we have a laser technology, high-power holmium laser, but especially super pulsed thulium fiber laser, TFL, that are able 4 times more than holmium to dusting. So it's very quickly, and for example, why not? One session of intrarenal surgery is probably also a choice for a 2 centimeter stone.
Yeah, so things are changing. Probably, I think that also guidelines will be reviewed, because with new technology, new chance of one-shot stone-free cases is available. Otherwise, yes, we will repeated in anesthesia, not easy, spine stress, double J, so a lot of troubles. So we
completely agree with Paula. The techniques are not so different for the many years. However, the devices which we are using for the lithotripsy are right now the more powerful and are decreasing the time of the surgery, and this is very important, I think. If you agree?
Yes.
For Paolo, very short question, because you were a pioneer of minimal invasive, okay, because you started a lot of years ago, but you was also an open surgeon, okay? Just beyond yourself. I ask you very fast, is there now, to you, a space to open surgery for these cases?
Personally, I don't think. Personally, I don't think. I am open surgeon in the past. Personally, I don't think.
I think that there's space for a robotic approach, maybe.
But laparoscopic.
And robotic with the robotic.
Robotic, yes, could be, but not open. Open, I don't. What does mean?
When we are in.
So, thank you, all the people. I think that we need experience, knowledge, devices, money, and probably we should centralize this difficult cases, which is increasing. I don't increase cases in probably in the stone center that should be everywhere spread on our countries. Thank you.
And I also think that we should think about the parents when we are adopting the procedure that it should all for example, one surgery when the child is around 5 years old. We should remember that when he will be 8 times, he could have another procedure, so the choice of the procedure is also very important.